Assalamu alaikum. I am Dr. Mahmud Tusar, lecturer, Department of Pharmacology in Bashundhara Ad-din Medical College. Today, our topic of discussion is drugs used in bronchial asthma. First of all, I would like to say a few words about bronchial asthma. What is bronchial asthma actually? Bronchial asthma is an inflammatory disease of the airways characterized by the episodes of acute bronchoconstriction causing shortness of breath, cough, chest tightness, wheezing and rapid respiration. In bronchial asthma, airflow obstruction is due to bronchoconstriction resulting from the contraction of the bronchial smooth muscles, inflammations of the airways and increased mucus secretion. What are the pathophysiology of the bronchial asthma? First of all, there occurs bronchoconstriction. It is usually due to the contraction of the bronchial smooth muscle and inspission of the thick viscous mucus plaques in the airway lumen, thickening of the bronchial mucosa from edema, cellular infiltration, hyperplasia of the secretory, vascular and smooth muscle cells. Here there is an overall pathophysiology. In this figure, we can see overall pathophysiology of the bronchial asthma. Now, we are going to drugs, anti-asthmatic drugs. First of all, it can be classified into two broad headings, bronchodilators and anti-inflammatory drugs. What are the bronchodilators? Bronchodilators further classified into selective beta-2 agonist, antimuscarinic agents and methylxanthines. Beta-2 agonist, in beta-2 agonist there are two types of beta-2 agonist. First of all is short acting and another one is long acting. Short acting beta-2 agonists are salbutamol, terbutaline. Long acting beta-2 agonists are salmeterol, formoterol. And antimuscarinic agents are Hypertroprium bromide, Theophylline bromide. Methylxanthines are the aminophylline, Theophylline and doxophylline. What are the anti-inflammatory drugs? Here there are some anti-inflammatory drugs. First of all, I am discussing corticosteroids. Here corticosteroids are hydrocortisone, prednisolone, beclomethasone, budesonide, fluticasone and betamethasone. In this, hydrocortisone is usually used in IV route and prednisolone is usually used in orally, and others are inhalational route, used in inhalational route. There are some leukotriene receptor antagonists such as montelukast, zafirlukast, and there are also some drugs, leukotriene synthesis inhibitors, zilutin, and mast cell stabilizers are cromolyn sodium and nitrocromyl sodium. What are the drugs used by inhalational routes? First of all, selective beta-2 agonists are salbutamol, salmeterol, antimuscarinic agents are Hypertroprium bromide, corticosteroids, beclomethasone, budesonide, fluticasone, betamethasone, triamcinolone, mometasone, and mast cell stabilizers are cromolyn sodium and nitrocromyl sodiums. All these drugs are used by inhalational route. In this figure, we can see the different types of bronchodilators acting on bronchial muscles, and for examples you can see in these figures, beta-2 agonist stimulates adenyl cyclase, whereas the theophylline it inhibits the phosphodiesterase enzymes, and theophylline also inhibits the adenosine receptors, and antimuscarinic agents inhibits the acetylcholine, binds with the M3 receptors of the bronchial muscles. All this contribute to the bronchodilatations. Beta-2 agonists. Now we are going to discuss about mechanism of action of salbutamol. Salbutamol usually binds to the beta-2 receptors of the bronchial muscles, which increases the adenyl cyclase, synthesis of adenyl cyclase, which ultimately increases the cyclic AMP, which ultimately then relaxes of the bronchial muscles and quick relief of asthma. What are the adverse effects of salbutamol? Salbutamol, first of all, it causes the tremor, tachycardia, arrhythmia, palpitation, hypokalemia and hyperglycemia. In this slide, we can compare between the oral and inhalational salbutamol. Inhalational salbutamol and oral salbutamol. First of all, I am talking about oral salbutamol. Oral salbutamol is very slow onset of action, and it is not selective in its action. It has lot of systemic adverse effect, and it undergoes fast pass metabolism. But on the other hand, inhalational salbutamol, this is rapid onset of action, selective action of the bronchial smooth muscles, and as it is delivered in the systemic, and it is delivered in the oral inhalational route, there undergoes no fast pass metabolism. So, no chance of systemic adverse effect. Now, we are talking about role of Hypertroprium bromide in bronchial asthma. Hypertroprium bromide usually blocks the M3 receptor of the bronchial smooth muscles, and it decreases the formation of the diacylglycerol and inositol triphosphate, which repolarizes of the bronchial smooth muscle, and it relaxes bronchial smooth muscles and decreases bronchial secretions. It relieves, ultimately it relieves bronchial asthma. Now, we are talking about the role of theophylline in bronchial asthma. What theophylline does actually? Theophylline, it inhibits, first of all, it inhibits phosphodiesterase enzyme, which ultimately increases the cyclic AMP, and it reduces the release of cytokines and chemokines from the inflammatory cells, decreases the immune cells migrations and activations, it competitively inhibition of the adenosine receptors, and all this contribute the bronchoconstriction and histamine release from the airway mast cells, and ultimately relief of asthma. Now, we are talking about adverse effects of theophylline. Theophylline, it first of all, it causes insidious tachycardia, palpitation, arrhythmia, and it also CNS, insomnia, headache, restlessness, and others, nausea and vomiting. What are the glucocorticoids used in bronchial asthma? First of all, IV route, in IV route we use hydrocortisone, in orally we use prednisolone, and in inhalational routes we use beclomethasone, budesonide, fluticasone, mometasone, triamcinolone. What are the roles of glucocorticoids in bronchial asthma? In bronchial asthma, glucocorticoids usually inhibits the influx of the inflammatory cells into the lungs after the allergen exposure. It also inhibition of the release of mediators from the macrophage and others cells, inflammatory cells such as eosinophils, and it also reduces the reduction of the microvascular leakage. It inhibits the hyperresponsiveness of the airways, and also it decreases the permeability of the blood vessels. Glucocorticoid actually do not relaxes the bronchial smooth muscle directly, they potentiate the action of other acute bronchodilators by their anti-inflammatory actions. What are the inhalational, is inhalational steroids are better than oral? Yes, of course, the inhalational steroids are always better than oral steroids, because in oral steroids such as prednisolone, and it also causes severe systemic adverse effects such as Cushing syndrome and adrenal suppression, and many other systemic adverse effects such as hypertension, cataract. But in inhalational route, there is minimal side effect and less, and there is minimum systemic absorption, and there will be few systemic adverse effects. What are the risks of inhaled corticosteroids? Inhalational route steroids are usually most common adverse effects are the oral candidiasis, most common, and it also causes the hoarseness of voice, dry irritation, dryness of the airways, and irritation of the airways. And the late complications or the long term complications are the osteoporosis, cataract, hypertension, Cushing syndrome, etc. How can we prevent the avoid of risk of the inhalational steroids? First of all, we can advise the patient gargling water and spit out after each inhalational spray. This was our today's discussion. Thank you everyone. Thank you for listening.